Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Saravanan Kasthuri. He's an interventional radiologist, and Jason McKitrick. He's a healthcare consultant and executive director at the Office-Based Facility Association. The Kevin MD article we're talking about today is Medicare payment is failing rural health. Everybody, welcome to the show.
Thank you.
Thank you.
All right, so I'm just asking if you to briefly share a story, then we'll jump right into the Kevin MD article. Saravanan, why don't you go first?
Yeah, I'm an interventional radiologist. I've been in practice since 2001 after completing my fellowship. And I practice in rural Washington for all these years and in Eastern Washington. And for about 10 years, till 2013, I've been in a big healthcare system or a local community hospital, which was bought over by a big system in 2011 or so. And what happened was the reason why I became a physician and why I wanted to take care of people with all the efforts of various things that we have to do to become a physician, it was at conflict, ethical conflict with why I became one, what I was expected to do, especially after the takeover by a big system. So I felt to keep my dignity and keep my moral compass straight to why I became a physician, one option was to start my own practice so that I don't need to be told what I should and how I should do and how many I need to see at a time. And so after a lot of thought process, meeting a lot of people, I did start a private independent practice for about 2 years. And then I still went to the hospital to do the procedures and realized that it was becoming untenable for them to be not their employee, to use their space. And I was spaced out of ability to continue to practice. So I decided, given the opportunity, to start an office-based setting where we were able to offer the complex vascular and non-vascular interventions in an office-based setting we call ambulatory surgical facility in Washington State, where you can do a lot of complex procedures like stenting, balloon angioplasty, and port placements and dialysis access interventions, so many things we could be done, which are typically used to be done in a hospital-based or ASC setting. And that was in 2016, I was able to get started. But over time, the reimbursement for the office-based space got very tight. And compared to for the same procedure that I used to do in 2016, for example, vertebral augmentation for people with severe back pain and who become dependent before they were independent, used to be about, say, $700-800 at that time. Now it is about $4,800.
Yeah.
So, and tell me between 2016 and 2026, in 10 years, what has come down by 40 to 45%. And my cost of care, like the staff I need to compete with the hospital-based services to provide, I've been paying close to 70% more for our staff, at least minimum. Some ICU nurses and all, we had to pay even more than what I used to pay in 2016. So the cost of care to deliver care has been going up. The vendors have been asking for more money for the same supplies. And it has been really a struggle, but the reimbursement has been going down. Sure. So that was the story that I've been facing and undergoing in a rural setting. The other thing is the ability of the patients to afford care. Yeah. When I started, the Medicaid percentage was like 1.2% in my practice in 2015 or so. And then now it is about 27%. So the ability of the patient to pay for those things are coming down, and the amount of reimbursements are going down, and the cost of care to deliver care is intense. And so we have to make intense changes and struggle to make things even to stay in practice.
Jason, why don't you briefly share your story and then maybe give us some context and some first impressions that you had when you first heard Saravanan's story?
Yeah, I'd be grateful for that. So, we represent, again, the Office-Based Facility Association. I'm a principal at Liberty Partners Group, and I've been really focused on, in particular, office-based care. And there's, I think, a little bit of a misconception what office-based care is. Office-based care is often private practice, freestanding, non-facility, place of service 11. These are all terms for it. They're often independent physicians, small businesses, rural providers like Dr. Kasthuri. and the kinds of care that you can provide across specialties, not just primary care, internal medicine, but interventional cardiology, radiology, proton therapy, radiation oncology, urology, vascular surgery, et cetera. It's a really important site of services. You two physicians know the three main sites of service are hospital, ASC, and office. But the office-based setting, you can do a lot. And as medical technology has advanced over the last several decades, more and more services can be done in an office-based setting, and it's the lowest cost side of service. And that's a great thing for patients. The problem is, and this gets a lot to what Dr. Kasturi was saying, is that when you look at the Medicare physician fee schedule, okay, when that was set up in 92, that was really focused on just the professional fees that a Dr. Kevin, a Dr. Kasturi would provide in any site of service. But as medical technology advanced, and you could take a $4 million linear accelerator or $4,000, stent out of the hospital and provide that care to a patient in the office, the money didn't go with it. And that's central to the problem because the physician fee schedule has been subsidizing the hospital outpatient fee schedule for several decades. And that has diluted the physician fee schedule for all physicians, primary care and specialists alike, but in particular has hurt office-based proceduralists. And at this point, as you mentioned in your article that was posted December 5th on Kevin MD, there are today more than 300 office-based services where the reimbursement is literally less than the direct costs that it takes to provide those services, the direct costs being those supplies, equipment, et cetera. And so it's why private practice, independent physicians have been going out of business. It's why the Physicians Advocacy Institute has talked about this collapse in independent providers, particularly in the rural settings. And so, we're grateful that the physician fee schedule regulation for 2026 is the first year in the last 5 or 6 years where office-based reimbursements actually gone up overall. That's great. And we are working with the Congress to really try to get permanent reform, which would really mean, as again, I'll reference your article from December 5th, would entail pulling out those supplies and equipment, high cost items from the physician fee schedule, take them out, reimburse those the way that you reimburse for those same services for hospitals and ASCs, which have their own technical fee schedules, and get the physician fee schedule back to just reimbursing for the work that you physicians do. And that's what we're really about.
So I'm hearing that it is very difficult and increasingly so for physicians to practice independently. We've talked about this on my podcast and on Kevin MD, how the number of physicians practicing independently is dwindling. Just to give us some context, Jason, approximately what percentage of physicians do you have data for are currently practicing independently today? Just give us a ballpark figure.
Well, I think, there's two great sources of information on this. One is the Physicians Advocacy Institute that I just referenced, but another one is the American Medical Association has been tracking this since about 2012, I believe. And what they have found is when they first started tracking this, that about 60% of physicians refer to themselves as private practice, and that has dropped about 18% over the last, since 2012. And, I think that that's a clear trend, and the correlation between those private practice that drop and the increase in physicians that are employed by hospitals, it's the inverse. And so, a lot of these private practice guys are consolidating, getting bought up by hospitals, and that's not good for anybody. It's not good for access. It's not good for, Medicare spend. And so we're really trying to do what we can to reverse that and to stabilize office-based care, including the kind of services that Dr. Kasturi provides in rural Washington.
Saravanan, you actually went against the trend. So rather than going to a larger conglomerate healthcare system, you actually broke off from one and went to an independent practice, despite the financial headwinds that Jason talked about. Tell us the impact that decision has made on some of your patients. And I know you talked about one of those patients in the Kevin MD article, but tell us the difference that made to some of those patients in rural Washington.
Yes. Even though as I said, I started this practice, I was separated off the system to keep my dignity. But the most satisfying thing is the high quality care that I'm able to provide, and also the type of people I'm able to work with who are motivated with a similar philosophy about I don't want to be told about how and these things should be done and what should not be, how I should not spend my time with my patients. So whether they are technologists or they are the nurses, they love being in the outpatient space with this one. And it is a level playing field within the practice. And so when a patient wants something done, we are able to see them within 3 to 5 days from the
Mm.
time somebody requests a procedure to get the procedure done within a week. But whereas oftentimes people come to me because they have been to the system where it takes about 2 to 3 weeks to even get an appointment with them. So the access to care is one of the main thing. The second thing is the cost of care. Like doing the same procedure, even if patients are going to pay only 20% out of the pocket, as we talked about, the at an average, they reimburse about 50 to 55%
Mhm.
for the same procedure as it is in the hospital space, sometimes even less. So it is about half the copay for the patient, so less cost for the patients in the system and better care because they could see them quickly. And also, you simply have to go to any of the independent physician services website on their reviews, Google reviews, or any reviews, including my services on Google, to see how happy the patients are. And the other one is we are able to have a human heart to feel the pain of the patient and see how we can help them. Like I mentioned in the article, one of the patients, which happened about a few weeks before when this happened, was he's a patient with gangrene,
Mhm.
intense pain. He was a rural working in a farm. He was one of the 67 employees who was given a housing in that place. And he has been working there for about almost 24 years. And his farm was on the verge of bankruptcy filing right now. It was an independent family owned farm. And then he had a gangrene, diabetes, gangrene in the foot. And he, as usual, happened to go to the hospital system, and they told him it will take 3 weeks before they can even see him and have the ultrasound and all those things to be done before, if it is something abnormal, they will see him. And then they heard about our practice and they came. And we were able to see him do the ultrasound and explain the procedure and schedule. So we were able to do within 4 days. And then as he was driving down that morning, he had a breakdown of the
Mm.
car and he couldn't. So it was about 8:15 or so we got the call, and then we changed our patient that we have over here. We called the later patients to come in early, and we took care of him. And then even though we were to start about 9 o'clock, we started him about 11:30. We got him done, and his leg was saved, no amputation, and it was all done within a week. And this is just a one example that I talked about, but we have multiple dozens of such patients where people with severe compression fracture, they're not able to get the care to be seen by the appropriate services in the big healthcare system for about a month or 6 weeks. And right now, if you want a cardiology consult for one of my family member, they said it'll take 7 months before they could be
Wow.
seen. And so there are months and months, but we are able to see in a short time. We're able to see for the half the cost, and we are able to see them on a one-to-one basis and taking care of the needs, putting a human face and heart about why we are in medicine.
We're talking to Jason McKitrick, healthcare consultant, Saravanan Kasthuri, interventional radiologist. The Kevin MD article that we're talking about is Medicare payment is failing rural health. Now I'm going to end by asking each of you just to share some take-home messages with the Kevin MD audience. Jason, why don't you go first?
I guess my take-home message is that we are finally getting the attention of policymakers in DC about, the value of office-based care, why it's important, why it needs to be stabilized, and would really just encourage folks to get involved. Feel free to contact me at the Office Based Facility Association if you are an office-based physician and want to really fix this problem overall. We've got the solutions, and we need folks to get involved and speak up like Dr. Kasturi.
And Saravanan, we'll end with you. Your take-home messages.
The outpatient services that we are able to provide for rural patients is so important. We provide not only high quality care, compassionate care, but also cost-effective care for those patients in a very timely fashion. If you want to preserve these things, you need to make sure there is at least a level playing field, not the current asymmetry in terms of reimbursement in spite of the better care they happen to receive. So when these practices consolidate and close down, it is not just the physicians who get affected, but it is the patients who are really affected because of that.
Saravanan and Jason, thank you so much for sharing your perspective and insight. Thanks for coming on the show.
Thank you.
Thank you. It's been a pleasure. Thank you.